From the California State Senate, this is Senate Spotlight.
Hello, everyone, and welcome to this segment of Senate Spotlight, where we discuss legislative priorities, policy, and other related issues with members of the California State Senate. From the state capitol here in Sacramento, I'm Brian Green, and in this special edition of Senate Spotlight, we're going to devote some expanded time to the discussion of an important topic related to the health of California's workers and their incentives to get healthy or stay healthy, the cost to employers, and whether those incentives are indeed fair and equitable. As mandates of the new Affordable Health Care Act begin to fall into place within the next year, the new focus will be placed on further reducing the rising costs of health care and the growing prevalence of chronic conditions. And a lot of that burden is put on employers. So to address that, employers are increasingly turning to workplace wellness programs. They are designed in theory to improve the health and encourage healthier behaviors of their workers. Well, there is an incentive and a disincentive at play here, frequently a carrot and stick approach to the process. The carrot, the incentive for an employee to be healthy, is often reductions in health care insurance premiums, or even free gym memberships, or even a water bottle. It can be that simple. Well, the stick, for those who don't participate or don't meet health care goals, can often be financial penalties or other punitive measures or privacy invasions. And thus, one of the increasing worries about workplace wellness programs is their potential to become discriminatory and run afoul of anti-discrimination and privacy laws and become a disincentive themselves. So we're going to talk about the dynamics of the workplace wellness programs and legislative efforts here in Sacramento to put margins in place to ensure that these programs remain equitable and that the appropriate incentives or disincentives are put in place to protect and ensure wellness in the workplace, if it's necessary or if that's even possible. Our guests here are our State Senator Bill Monning, representing the 17th Senate District along California's Central Coast, Carmel, Monterey, Santa Cruz. The Senator is also the chair of the Senate Budget Subcommittee 3 on Health and Human Services. And when you were chair of the Senate Assembly Health Committee back in your time in the Assembly, I know you were instrumental in establishing the California Health Benefits Exchange, which is our California version of the Affordable Health Care Act. Senator, welcome.
Thank you.
And Anthony Wright is with us. He is the Executive Director for Health Access California. That is a state care consumer advocacy organization. You've been there for, a decade or so plus, and you are a leading voice, along with your organization, for healthcare consumers in California. And you also led California's coalition effort to help pass the Affordable Care Act. Yep. And also with us is Dr. Francisco Prieto. He is a medical doctor, family physician based in Elk Grove here in Northern California. He's affiliated with the Sutter Medical Group here in Northern California and also with the American Diabetes Association. Doctor, welcome to you. Glad to have you here. And I don't know if you were part of the creation of the Affordable Care Act, but if not, you've definitely been affected by it.
Supported,
so, yes.
Waited a long time for us to put something like that in place.
Right. Well, we're very glad to have all three of you here. Let's get into this and kind of set the scene, especially with you, Senator. The Affordable Care Act mandates are forcing us to look here in California at the costs of health care, health maintenance, and health prevention. So I guess the logical place for employers who are focused on that and burdened by that, if you will, are to turn to something like workplace wellness programs. You agree?
Absolutely. And again, I think the basis of the legislation that I'm carrying that we'll talk about, we fully support trying to make workplaces healthy workplaces, to give incentives for people to pursue achieving their own health goals. The concern is to protect the consumer, and in this case the worker, from any shifting of cost or penalty or discrimination that could be based on a pre-existing health condition, that could be based on motives that aren't as pure, but shifting costs onto a group of workers who, through no fault of their own, may have a pre-existing health condition, may be dealing with a health condition where a medication they take results in weight gain, not a desired goal of the employer for employees to achieve weight loss. So I think, simply put, we want to make sure that wellness incentives, health promotion programs at the workplace are designed to promote health and wellness, but to protect against shifting of costs or discrimination based on a pre-existing health condition.
Let me ask Anthony or the others to chime in too. Let's go to the basics here on this. What is a wellness program and how does it work? How many are we seeing out there here in California? When I first saw this, it kind of fell into the file of, I didn't know that this was a problem. But it is indeed. It is something that comes out as a result of ACA.
Well, I think first of all, it's important to recognize the Affordable Care Act puts a major emphasis on prevention and wellness. It includes the biggest investment in prevention and public health that Congress has ever done. It puts resources into things like community transformation grants so that communities are more walkable and people have more access to healthy choices in their day-to-day lives. But if you're going to do that, a lot of people spend a good portion of their day at work. And so are there things that can be done at the workplace to encourage people to be healthy? There's a lot of good evidence, for example, that a big thing that employers could do is encourage either public transportation, biking, or walking to work. And so that and so there are things that employers could do there. There are things within their the walls of their work site, whether it is providing presentations about nutrition, or even allowing for the space for a yoga class on the side. That could be very beneficial not only to the workers but to the company as a whole. However, as the senator said, you want to make sure that there's a balance between that and putting in incentives that actually work the other way. Penalizing people for their health status, and actually then, if that involved, for example, having a surcharge on either the premium or cost sharing to get access to care, that could actually have a negative impact because that puts a financial barrier between people and the care that they may need. So I think this is really important legislation to sort of strike that balance between encouraging prevention as much as possible, but also not wanting to put disincentives or barriers for people getting the care that they need.
Dr. Prieto, I imagine you are involved in these wellness programs, very familiar with them, obviously, through your capacity affiliation with Sutter and also with the American Diabetes Association. What is a doctor's role in these wellness programs? Do you just work through your relationship with the patient, or do you actually counsel workplaces?
I do a little of both, but just as a practicing physician, I mean, I see the ramifications of this every day. To give you one example, one of the things that some employers are doing, one in our area, is giving their employees an incentive if they complete a form showing that they've seen a physician, had their blood pressure checked, had their cholesterol and their blood sugar checked, obviously dealing with the diabetes epidemic, and just for having done that and gotten the information, separate from whatever action they take with it, they're being given an incentive. And there are all sorts of incentives, as you mentioned, carrot and stick, based on simple behaviors, sometimes based on more complicated behaviors. The ones that worry us a little bit are the ones based on outcomes that may or may not be under the patient's control. I'll give you an example. The last thing I did before coming here was see a patient who I've taken care of for several years. He's sort of a cautionary tale about the Affordable Care Act, or why we needed that, but I'll get into that later if we want. But he's had diabetes since his late 20s. He's actually slender now. He wasn't always, although he was never obese. Has had multiple complications. He's now 51. He has basically failed all oral treatments, and the last thing we did today was decide that he would have to start insulin because he's basically not making it anymore, and we all need insulin to live. One of the downsides of insulin, because we can't give it exactly the way a good, well-functioning pancreas does. I mean, we try very hard, but you cannot duplicate what a good pancreas will do, is that it stimulates your appetite. It's what we sometimes call a hunger hormone. And so in giving this to him, and he's at a normal weight right now, I know that within the next few months, I'll have his blood sugar in much better shape. He's also probably going to gain some weight. Now, if he were working for an employer that used a stick-type disincentive for weight gain, then he'd get penalized for that. Something that is totally out of his control, that in fact is a consequence of his trying to do something to control his disease better, and it will ultimately keep him alive longer, but he'd be penalized. So we don't want to see that kind of incentive that's really perverse, if you will.
And now, Senator, it said that your legislation, Senate Bill 189, sort of moderates those carrots and sticks in the creation of these wellness programs. Give me a few more details on what you want to do with this. And obviously, states have the rights to make these kind of independent decisions regardless of what ACA says, right?
Well, that's right. So the ACA does establish and encourages wellness programs in the Affordable Care Act, it is transformative for many families in this state, in this nation. As Anthony mentioned, the commitment to prevention. It also provides for employers to provide wellness incentives, and the federal law allows for a variation in premium payments based on health status or outcomes. That's where we're concerned, and we believe California can implement the good intentions of the Affordable Care Act while protecting against adverse and unintended consequences, as both Dr. Prieto and Mr. Wright outlined. So we just want to make sure that we encourage participation as appropriate. So a walking program would not be appropriate for somebody bound by a wheelchair through no fault of their own, an accident, a genetic inheritance issue. So we want programs designed that encourage participation, and you can also reward participation. We've seen programs in Europe, we've seen some programs in the United States where the reward is not connected to the premium payment or copay costs. When you start mixing with raising a premium payment for somebody who doesn't achieve what's determined to be a desired health outcome, but you haven't factored in a pre-existing condition or a socioeconomic condition, not everyone comes to the workplace from the same circumstance. There may be somebody from a lower socioeconomic background who's taking a couple of bus rides to get to work and has to pick up children at childcare right after work, versus the young 20-something single guy who can go to the gym every day at 5 o'clock. So we want to make sure these programs are designed to encourage health and to encourage and reward participation. Some of the European programs have done that by quarterly or biannually providing a credit card coupon where you can buy some sporting good clothing or things like that, or at another retail outlet. Water bottles you mentioned. There can be different types of rewards, but what we want to protect against is not having somebody who we want to make sure has access to health care, has access to Dr. Prieto, to work with them on controlling their diabetes. If they're penalized at the workplace and have to pay a higher premium, they may say, I can't afford that. I've got to pay rent as well. And the very person that we want to get into a health program and have regular monitoring and counseling from a physician, and not from the employer, but from a physician. And that's what we want to encourage in this legislation. And then as a final comment on that, we also think it's very important to protect that doctor-patient relationship as confidential, and that health screenings should be something that is shared between a patient and a doctor. We don't want employers to use a health screening to say, this person not only has high cholesterol, they're also HIV positive, and then the next week they get a termination notice. Not related to that, but perhaps induced or inspired by that knowledge. So we want to protect the sacrosanct relationship between patient and doctor, not have employers using it in a discriminatory fashion.
Or even a supervisor, as I sort of alluded to before we started here, walking down the hallway. Whoa, I see a Twinkie on your desk. You're eating Twinkies.
Right.
That's a health issue. That doesn't necessarily align with our wellness program. Right. Anthony, your comment.
I think this legislation provides important guidelines for how to implement and improve upon the Affordable Care Act. And, perhaps the most popular provision of the Affordable Care Act is the ban on denials or discrimination based on pre-existing conditions. It's something that people sort of really treasure, both because they feel that even if they have good coverage now, there may be a moment where they're buying coverage as an individual and be in that situation. But there's also really another important goal of that provision, which is we want to move away from the world where insurers compete based on avoiding risk, on avoiding sick people, on making distinctions between the healthy and the sick. And so we want to make sure that these wellness programs, if done correctly, encourage people to get well, but we also want to make sure that they don't become a tool for what we would call backdoor underwriting, making distinctions between workers and patients and policyholders to the point where people could be segmented based on risk, and that allows the insurers to go back to the sort of the game playing that we're trying to move away from with which is the whole structure of the Affordable Care Act. We want insurers to be focused on getting folks well, rather than saying, hey, we can actually discourage some people from taking up this coverage if we raise the cost on them, and that's what we want to prevent.
Well, you had mentioned the issue of biometrics, and also you mentioned genetics, and there's still a debate in this discussion about genetics versus lifestyle. And in fact, some of the opponents of the senator's bill say, lifestyle is a big part of it. A lot of these things we attribute to genetics are not necessarily so. Doctor, your perspective on that?
Genetics is a very powerful thing, and this patient I mentioned to you earlier today is a good example of that. Of his, I believe, 7 siblings, 2 have already died from complications of diabetes and heart disease. So I told him, maybe the best thing that could have happened to him is if he could go back and pick new grandparents. It's just not an option, and we don't have that choice. So I think you also have to look at sort of the basic behavioral concept that positive rewards are a better way of changing people's behavior, and if that's what you want to do, moving them in a healthier direction than punishments or threatened punishments. We've seen kind of a perversion of the whole idea of insurance for many years, this whole notion of cherry picking. We'll insure you if we can be sure you'll never make a claim. And the whole idea of insurance, I thought, is to protect you against things possibly unforeseen that could happen to you, and be sure that you're taken care of if they happen.
Well, sorry, go ahead.
No, that's fine.
Oh, well, I was going to say one other thing I was thinking of as you brought this to mind was somebody had compared this type of thing, these wellness programs, health insurance, to auto insurance, that the safer you drive, the cheaper it's going to be and the better off you're going to be. Is that an unfair comparison and metaphor? Anyone?
Yeah, I think it's an absolutely unfair comparison. I'm glad you raised it, because that will be one of the arguments that it's appropriate to measure your driving record. When you try to transfer that philosophy of how you rate insurance premiums to somebody in the health arena, it's really apples and oranges. And for many of the reasons we've discussed that Dr. Prieto identified with his patient, people come to the table with now guaranteed issue of health insurance under the Affordable Care Act, with very different genetic backgrounds and predispositions, with different health histories, and with different capacities to achieve certain preferred health goals. On a driving record, it's real easy to measure tickets, speeding tickets, accidents, etc. With somebody's personal health record, that's a private, confidential health record between them and their doctor. And secondly, you take any workplace of 100 employees, they're going to have all different health histories and backgrounds. What we want to do is really incentivize participation and recognize that those with the greatest health risks, we want to make sure they're covered and they don't get priced out of the market because of cost shifting, that it's prohibited to deny somebody because of a pre-existing condition. What we don't want to do is have employers or insurance companies being able to raise rates for those that present the greater risk, the kind of cherry picking with the hope that we know they won't be able to afford that coverage. They'll drop out. They're no longer a liability for us. They become a liability for all of society, and it misses the mark. The Affordable Care Act is designed to provide insurance coverage and to promote health. So that's what we want to do through this bill: protect the coverage and promote health.
Now, you had mentioned earlier the tricky part about the incentives on the benefits, the reduction in benefits as an incentive to participate and participate efficiently in these programs. I know ACA globally here in the United States will allow that, and I think, was it the 96, as we know it as HIPAA, the Healthcare Reform Act also encourages that. So that element of this is nothing we're new to, correct?
It's not, but under the Affordable Care Act, for the first time, it's being recognized as an important tool, but under a new notion, which is guaranteed issue of health insurance, comprehensive coverage, and we believe in California to achieve those goals with our very diverse population, our very diverse workforce. Let's have the variations be in rewards for voluntary participation, not in the very fundamental access to the health care coverage.
What are other states? Yes, go ahead. Go ahead,
I think
Dr.
the basic principle here is you want people to try to control the things that are under their control. Genetics has very little to do with your driving record, but it has a whole lot to do with what health risks you face, what health conditions you might develop, and it's just a basic issue of justice and fairness to not penalize people for things that are not under their control. But you also don't want to do things that just flat don't work. So if we price people out by, in the form of negative incentives of some reasonable amount of coverage, it's not that those problems go away or that we don't end up paying for those problems. We just shift them somewhere else. We shift them, to the hospitals, to, more costly, more complicated, less effective care. And that's one of the things I think the ACA is trying to prevent, is get people into the system, cared for, and prevent those preventable bad outcomes.
I wanted to talk about what other states are doing, and maybe you can weigh in on this too, Anthony, and what your bill might have been based on from other states. I know some states in the nation are mirroring the Affordable Care Act and its mandates. Some are doing what you're trying to do here in California. Both of you, perspective on what other states are doing too.
Different states are taking different tacks at this, and that's appropriate, and we'll learn from that. I do think one of the things that we want to learn from is the evidence, right? There is a number of there is good evidence on, for example, walking, biking, taking public transportation to work. There is less evidence. This is a relatively new field on a lot of these other areas, and so we want to build up some evidence before mandating or requiring some of these types of wellness programs. I think the other piece that's important is what we're seeing by employers is that some are using this as basically a vehicle by which to simply shift costs onto workers. That at the end of the day, there has been a general trend of employer-based coverage being whittled away at when employers are getting premium increases, shifting that burden onto workers, and this has become in some cases a way to do that. And if that's the direction that the employer feels that they need to go in negotiating with their workers, then that's the discussion. But we shouldn't sort of use this as sort of a backhanded way to do that, right? Mm-hmm. And that's, I think, another part of why I think this legislation provides good guideposts for how we can move forward.
Yeah, and I would just add, as Anthony said, there's no really good evidence that shows that the carrot and stick on the premium payment results in better health outcomes. We do know from some peer-reviewed medical literature, not the ideas of politicians or policy advocates, but peer-reviewed medical literature, that some of the most effective incentives are rewards for participation, not linked to premium payments. So in essence, we're trying to establish some more precise guidelines to achieve the objectives of the Affordable Care Act and to protect workers as consumers from this cost shifting in a manner that would ultimately be discriminatory and violate the very goals and objectives of the Affordable Care Act.
On a legislative level, this has been tried before here in California, right? Wasn't it last year that a similar piece of legislation did not make it to the governor's desk?
That's right. I carried a similar piece of legislation last year. In the final rush, it was really not defeated on the merits. It was held in suspense, and I think we're all a little bit more informed now as how the state is moving forward with implementation of the Affordable Care Act. The governor's made it clear that California is opting in for the Medicaid expansion here, Medi-Cal, that will afford access and coverage to 1 million to 2 million Californians currently without coverage in the next year to 18 months. So this is pioneering work. There are many moving parts to the implementation of the Affordable Care Act. We feel this is a very important piece of that, adding a little more detail, a little more precision and predictability to promoting health and wellness while protecting workforce and consumers.
Senator, the opponents to this bill have come to you and say, look, these programs do work. That kind of like, you can do it if you try. that there should be some motivation for personal accountability and personal responsibility. And if not these incentives, and this maybe goes back to what we've already discussed, what kind of incentives then make up a good wellness program?
Well, again, and the others may have comments, but we don't prohibit in this bill using incentives. We're just saying the incentives should be managed in a fashion that promotes voluntary participation and is not focused on health outcomes or on pre-existing health conditions. And again, we have seen programs where that reward system for participation has proven effective.
Gentlemen, comment on that?
Yeah, I think, and just speaking for the Diabetes Association, we believe in incentives and we support incentives. And just as a physician, I see that, if you give people a positive reward for something, that influences their behavior. What we don't want is to see people being discriminated against for something that some people outside of medicine may think is under their control, but is not necessarily. And one of those things is outcomes, and I treat a patient, I'll tell you that, you have this condition and we're going to do this and this and this to try to control that. But I can't guarantee the outcome. I can't guarantee you that the treatment is going to work. I can't guarantee you that something works in fact, I can guarantee you that something that works one way in you is not going to work exactly the same for you. You're different. You're genetically different. Just all the particulars of your life are different. But participation, for a positive incentive is going to be a good thing for either of you. For example, if there's an incentive to participate in some kind of a fitness program, maybe, get cheaper parking if you park in the parking lot that involves a 2-minute walk, It sounds small, but that would be a good thing. That's going to influence both of you in a positive direction, but the outcome may be different. It may make a huge difference in your health. It may make a very small one in yours, and there's no way to predict that.
What this bill does is it focuses our efforts on what we know works. That there are a lot of workplace wellness that I think and a lot of good innovation that's going on. Whether it is, I see more offices with desks with treadmills, so that people can walk while being on their conference calls. I see.
It's hard to type.
I see more activity in terms of challenges within a workplace to sort of with people with pedometers on their as they walk around the building and maybe walk for lunch. I see. I think there's a lot of good and innovative stuff being done, and I think that's to be encouraged. And certainly the employer has an incentive for having their workforce healthy, not just for productivity, but for also the premiums that they share with the workers in paying. But there's, again, the issue is when you tie it to the premium, when you tie it to the cost sharing, when you do some of these other things, that's where I think that there is some real concern, and the evidence is just not there. I mean, the most research that has been done, and the most prominent of these, is that the savings that we yielded to the employer was about the cost shift to the worker rather than any sort of inherent getting workers healthier. That in fact, that there was a savings to the employer, but the savings was entirely because it was just simply shifting that cost to the workers, not about getting folks healthy. And if that's the direction that we're going in, then let's be honest about that. But let's not use wellness and create some of these disparate impacts as a result.
And we are wrapping up here, and gentlemen, as always the case in these programs, we scratch the surface and so much to talk about. But just finally, Senator, I know that this bill is getting ready for policy hearings as we speak. Folks can find out more information about the legislation and the other activities going on through your website, right?
That's right. They can check our website. They can contact our offices listed there on the website, and we appreciate this opportunity to share some of the thinking behind SB 189.
Great, thank you. Is there anything, just a parting shot anybody has of some glaring thing that we might have missed? I just want to make sure.
No.
Okay.
Thank you for
Great. No, I appreciate all three of you gentlemen for, this is obviously an important issue. It affects a lot of Californians in the workplace and outside of, and we appreciate you taking the time to be with us. Of course, State Senator Bill Monning from the 17th Senate District, who is the chair of the Senate Budget Subcommittee 3 on Health and Human Services, the author of the bill, Anthony Wright, the Executive Director of Health Access California, and Dr. Prieto from here in Northern California, a family physician affiliated with Sutter and also with the American Diabetes Association. Thank you again, gentlemen. And that is it for this edition of Senate Spotlight. So we invite you to join us again next time around as we discuss important legislative issues and policies with the newsmakers and newsbreakers of the California State Senate. From the Capitol in Sacramento, I'm Brian Green. Thanks for watching.
Thanks for watching Senate Spotlight.